All right. Well, good morning, everyone. My name is the Reverend Vernon K. Walker, Program Manager of the Communities Responding to Extreme Weather. We are glad to be here today. I am with my colleague, Anna. And for those who may watch this video and who may not know what CREW is an acronym for, CREW is an acronym for Communities Responding to Extreme Weather. And we help prepare communities in an equitable, inclusive, and sustainable way to respond and to prepare for climate change, the extreme weather that comes as a result of climate change, such as heat waves, floods, etc. The purposes of why we're here today is because we are living in a very interesting time. We're living in the best of times, the worst of times, all at the same time. C.S. Eliot, a quote from C.S. Eliot, but we are living in a time where we have a raging pandemic going on, but hope has come in the form of vaccinations as many people are as various across the country are getting vaccinated. And that is a great sign of hope. And the purposes of this discussion is we are going to engage with one of the prominent infectious disease doctors across the country. And we're glad that she's here with us. And, to really answer some questions, to dig deep into the vaccine. We know that there's 3 vaccines out, at least and particularly being used in America, Johnson & Johnson, Pfizer, and Moderna. But to introduce that a little bit more, we have Dr. Regina with us from MGH. And she's an infectious disease doctor from MGH and has been practicing for quite a few years now. And she is doing extraordinary work around vaccination, around vaccination education, and helping to clarify and demystify the process around getting vaccinated and really what that entails and how that protects people from getting severely sick from the coronavirus, as unfortunately millions of people across the country, across the world, have unfortunately experienced untimely deaths, and over 545,000 people have experienced an untimely death due to the coronavirus. So I want to put a pin on it from my angle at this point. And I want to introduce Dr. Regina, and please come on to the virtual mic, if you will. And perhaps you could tell us more about yourself, Doctor. And we're so glad that you are with us, and we're so glad that everyone that on the call has taken time out to join us.
Well, thank you, Reverend Walker. It's a pleasure to be here with all of you. I think you've done a lot of the introduction already, but I'll just say that I'm an infectious disease physician and researcher at Mass General Hospital, and I'm Associate Director of our new Center for the Environment and Health at Mass General Hospital. So I think that our shared interests are overlapping now in terms of infectious diseases and emergency response as we see how the COVID pandemic is playing out. So as all of my colleagues have been, I've been very involved with talking to people about the COVID vaccines, I should say, and I'm happy to be here today to be in conversation with this group about the challenges that we're facing in emergency preparedness, and obviously that overlaps a lot with what we're facing with climate change.
Thank you for that. And perhaps before we go into the Q&A, or not necessarily Q&A, but to a more discussion, if you will, I just want to point out, someone may ask, well, what does a climate justice organization what is the interest of a climate justice organization and a health justice issue or a health issue? Well, there is an intersection where healthcare and connects with climate change. For an example, we know that when there are extreme heat wave events, people such as elderly and folks that have certain underlying conditions are more vulnerable to suffer heat stroke from extreme heat. And the last 5 years have been some of the hottest weather in human history. And we know that as the climate becomes warmer, tick-borne illnesses are starting to make their way into the Western Hemisphere. And we will start to see more spreads of infectious diseases, such as more like Lyme disease, for an example. And we will start to see malaria, for an example, which has predominantly been in places like India, come over to America because these mosquitoes that are carrying these diseases are attracted to warm climate. So for us, there is a intersection where healthcare connects with extreme heat because or healthcare connects with extreme weather because as we've seen, climate change will impact the whole world, but it will disproportionately affect frontline communities of low wealth, communities of color more because of these communities being at the front line. So that is the interest and crew has in hosting events like these and doing events like these because it's all interconnected. And again, when we think of extreme weather events such as Katrina that hit New Orleans in 2005. Well, a lot of people unfortunately lost their homes, and unfortunately some people died because of the hurricane. So it is on that note that we will open it up here for Q&A to hear some discussion, to hear some thoughts, some questions, some ideas that we'd like to discuss around our vaccination preparedness. Maybe I can hand it to Anna to ask the first question.
Thank you, Vernon. So my question is mostly about the side effects of the vaccine, which I think a lot of people may be worried about or unsure of for different reasons. And I was just wondering, why are there different side effects for this vaccine specifically? How much do they affect people? Why are different people affected in different ways? And what should people expect following their first or second vaccine dose?
I'm happy to answer some of those questions. I think that, I just want to say I appreciate what Reverend Walker just pointed out very clearly, which was that we know well that there are immediate and specific effects on human health that we are seeing already in regards to a changing climate. And we know that some populations of people are already more susceptible to not being able to handle shocks to society. And that's something we've seen during COVID very clearly. And so how do we plan to be sure that, we don't leave people behind as we respond to emergencies? I think that's a really big theme that we're having to struggle with during COVID. So I appreciate Reverend Walker's formulation of all of that. I think with regards to some specifics about the COVID vaccinations that are happening in the United States, many people have questions appropriately about these vaccines on a number of different levels, just ranging from how they were developed to how they work, to how they're going to change how we approach COVID going forward, to just the basics of how do I feel after I get a vaccine. So I'm happy to take that specific question that you just asked. So, we do know that all vaccines can cause, reactions. commonly they cause a sore arm. And, rarely vaccines have unanticipated adverse events. And we have a robust system in place in our country to monitor for that, particularly after this vaccine. So I think the thing I like to tell people is that you are going to have a sore arm after receiving this vaccine. And some people also feel systemically unwell. By that, I mean a little fever or fatigue. That's particularly common after the second dose of some of the mRNA vaccines. And so these are things people should be prepared for when they're receiving the vaccine. That doesn't mean that the vaccine is causing a problem. In fact, it may mean that these vaccines are working just as we want them to, because we want your body to mount a response. Typically, those reactions or side effects occur within 12 to 24 hours of getting the vaccine, and they go away shortly afterwards. And it's not universally experienced. So you might feel a sore arm, you might feel a little bit unwell, but that usually goes away relatively quickly.
Thank you. Yes, go ahead, please.
Thank you, Reverend. Dr. LaRocque, we host a number of different forums on the vaccine, and one of, actually a couple things that we try to continue to amplify, but I think is important in this discussion is, the first one is many people think that the current vaccines actually have a live virus in it. And so we like to amplify that that's not the case. And then there's another group of people who are very concerned about the way the vaccines were designed, specifically, I believe, is a Janssen using stem cells. Could you speak to that for our audience? Thank you, ma'am.
Yeah, I'm very happy to talk to that. I think that I just want to share, I've been talking with lots of different communities over the last couple of weeks, and it's been a learning experience for me too, to hear about what concerns people have and what the common questions are. So I think, what you're saying, Mr. Roy, is these are common questions. Maybe I'll provide a little context and say one really big question is how are we able to develop so many vaccines so quickly when that hasn't typically been our experience? And so, I'm actually a vaccine researcher myself, and I like to emphasize to people a couple of important points on that front. One point is that the biology that's behind these vaccines is very well-known biology that we've been working on learning about over decades, and that the technology that has gone into developing these vaccines has been being built up over a very long time, just for the very purpose of what we see now, to be able to make vaccines in a very scientific, precise way. And a lot of that technology came about from what we learned from the other coronavirus near-miss pandemic with the SARS-CoV-1. And so in many senses, we are now reaping the reward of the preparations of our research infrastructure that we put in place after that event. So we were ready to be able to use biology to make vaccines in a very precise and smart way as soon as this virus emerged. But the process that these vaccines went through in order to be approved and begun to be used was the same process that we have in place for all vaccines that we use in the country. There is a standardized, rigorous approach to develop and test these biological vaccines before they are given to people. And these vaccines went through all of that same process. It involves a lot of review by many scientists and physicians. And actually, after the vaccines are given, we also have systems in place to monitor for any unexpected events. And we now have given these vaccines to tens of millions of people. So we have been able to monitor to see if anything unexpected has occurred. So the point being that the technology and the knowledge was in place, and that was one reason why we were able to do this. The safety systems and processes were in place and applied to these vaccines also. and that now that they are being given to many millions of people, we also have systems in place for seeing how people do in the real world as they get the vaccines. And in some senses, the fact that we have identified this rare allergic event to the mRNA vaccines is some reassurance that these systems are recognizing if there's a unexpected thing we need to watch people for. And so consequently, those of you who may have had one of the mRNA vaccines, you know that we monitor people for 15 minutes or so after getting the vaccine to be sure that they aren't having an allergic reaction. These are very rare, but we're monitoring for them.
So doctor, I have a question. I think I have one that I want to just think of arriving at later, which is around vaccine reticence and sort of the community aspects of this. But we stood up the first month of the Reggie Lewis, and we were just dealing with Pfizer at that point. But we're opening up mobile clinics now with the support of a lot of partners. And one of our operational challenges is, I think it's vaccine transport, like sort of like the temperature management is, I don't know if it's Janssen or Pfizer, where we're really worried about jostling vibration of the vaccine vials themselves as they're being transported. If we try to stand up a church for a 4-hour vaccine with a mobile clinic, like what are the aspects of transportation that we need to think about as we find our new vaccinators and new operational managers to help us with this field operation?
Well, I think you're putting your finger on what was one of the limitations with the mRNA vaccines that were the first ones to come on to availability, which is that it's a very delicate biological substance, this messenger RNA, and it requires being stored at cold temperatures. And I'm not as familiar with the jostling issue, but I do know that the vials, you don't want to shake them too much. I'll just say I don't know if driving in a car is a particular issue, but they have to be handled with more care than some of the standard vaccines that we're accustomed to delivering. And that definitely has been an operational challenge. I think that's why a lot of hope is now pinned on the more widespread availability of the Johnson & Johnson vaccine, which doesn't require as complex logistics for handling it, and also only requires a single dose, because in addition to just the sheer handling of the vaccine itself, having to get people 2 doses complicates the rolling out of it to many communities as well. So is that what you're?
Definitely.
I mean, I think that, oh, look, Georgia, you look like you were going to say something.
Oh, I just have a question, but Courtney, please finish. Thank you.
The reticence question, I almost think it's for this whole team as a whole. Just like where we think the general attitude about this is. I think when we're dealing with elders, I think that was one population. As I'm getting down to 20 and 30-year-olds, what I'm seeing in the community is almost like a false sense of security. So our teams have definitely seen an audience of like 75 cars and 150 people out in public as if there is no environmental threat anymore. So I think as we open up the waves of engagement or potential eligibility, I think we might see reticence play out in that way. But one of our centers opened up on Talbot Avenue, and the line was around the block. So there is a high demand still for the populations that are currently accessing it. And framing all of this in some kind of equity and co-occurrence and intersection of other hazards, like what we expect to happen this summer, would be an interesting dialogue, I think, for folks. Thanks, Georgia.
Thank you, Courtney, and great point. And thank you so much, Dr. LaRocque, for sharing your knowledge and insights with us. I have a question, and it hopefully dovetails on what's been asked already. Looking at the communications aspect or messaging aspects for diverse communities, we know that words matter, and they matter greatly. And so I was just wondering if you have any points that you could share with us in terms of how you or your establishment has addressed some of the communication challenges around building confidence around the vaccinations for diverse communities. We know that all communities have unique ways of communicating, may have some historical context for what we may see as why they deliberate maybe a little bit more around the vaccine? What has been your experience?
Yeah, thanks, Georgia. It's really an important question. I mean, because there's a really key difference between having a vaccine and having vaccinated communities. And, I think one of the areas that we struggled with in our country and that we're making progress on was we certainly put a lot of time and effort and resources into developing these biological vaccines. But, it's similarly a lot of time and effort and thought that needs to go in. How do you reach communities and make sure that there's access to the vaccines, particularly in the most affected groups? Harder to reach people in our societies. How do you get the vaccine to them? How do you communicate with people about this? It is a moonshot of its own to do that work. And, I think we're beginning to see that rolling out now. It's very important because COVID has not affected everybody in our society in an equal way. And we know that. We know that Black communities, Hispanic communities have had higher rates of infection and higher rates of death, and that we have to represent that real lived experience in how we approach them with vaccination. And so there's a lot of challenges. And we know a lot that, how do people think about vaccination? Well, I think there are real issues of trust that we have come up against as the vaccine rollout is happening. And, frankly, I think about the trust issues as in two buckets. I think there's some real earned mistrust of our medical system, and that has many historical and current factors that underlie it. We also have, just some issues of provoked mistrust, I would say, with our media landscape nowadays and our kind of societal levels of trust in institutions having declined for a long time. So they're two challenges, but they're different challenges. So we know that people, who people trust are who they know, people that are part of their community, people they know, people they have personal experiences with. And those are the people who we really need to have out there communicating about vaccination and engaging those messengers in the campaigns, I think is essential. And it's very complex work. It's on the ground work. It's interdigitated into communities. It involves really knowing who the influencers and asking people, what they need to know and listening. So it's hard work and it's people work, but it's really how we're going to emerge from this. So I think I may have gone on a little bit, but that's my sense of it.
Great context and content. So thank you so much.
I have a question that expands on that a little bit, and is actually, I sort of want to open it up to everybody. I think a reoccurring word I've been hearing is experience, and overall, I think COVID has been a learning experience in every sense of the word for so many people. And I was just wondering if all of you, given your different expertise and backgrounds, could speak to what you have learned and what you will be using going forward, or what governmentally we have learned and will be using going forward, healthcare wise, what we have learned and will be using going forward, and also just individually what we've learned and will be using going forward.
I might try to chime in on this. So we're almost like a hybrid of community partner as well as agency, and one of our roles is the Public Health Institution for our FEMA region. We tried our best to engage community partners, and we found a way to give out $4 million to 220 of the partners, so $20,000 on average each. And our first shock was how many of them had almost little to no relationship with the Health Commission beforehand. I mean, we were getting like love messages from folks thanking us for helping other people receive funding for the first time. And all of these agencies were folks that people had been depending on for years, regardless of this incident. but definitely for COVID-19. And then really educating the institution on something that we no longer, I no longer call it community engagement, like engaging the community into something we're doing. If anything, it's reversed. The community has been taking care of each other for years, and we've been absent from it. So how do we integrate into that and join and leverage their system? So all the mutual aid folks, we have about like 25 videos now of what they have been doing beforehand and what they did with our funding, even down to having radio shows from 11 to 1 in the morning, explaining like what reentry and sort of reentry phases are. Like, remember now we're at phase, 4, step 1. I'm like, I don't even remember all the phases. And they're really, really clear about that in things that we could never do from the commission standpoint. Like there's a certain branding and language you use when you speak from a corporation, from a large public health institution. So that was one. And then the workload to handle that while also running operations, which I think hampered our office because we are emergency management. We had to reassign staff to even handle giving out $4 million in 4 weeks. And then also helping those institutions do their work. And I think it's almost like we have to help support this network of folks with technical assistance and such, and then really leverage them to get through what I consider the long-term phase. And also the last piece is, after stopping people from dying and getting sick, the wave of psychological impact that we're going to be stuck with, and that very little conversation is oriented around. I'm a little bit scared. If you think about Katrina and marathon bombing, after the recovery phase, mental health and psychological issues were overwhelming. And COVID-19 has hampered our ability to serve 2,500 people in 5 weeks like we did with the marathon. So I think what we're getting in terms of reports, I had 3 suicides of 30-year-old people of color in 7 days. No, they didn't complete, but they were all interventions that we had to do what we call as interruption for. So I'm deeply concerned about that. And I think there's a lot of conversation around, response in the beginning when we stood up our medical intelligence center, and now the things business is doing really well. The human business, I really want to get some support around that. And Will, I realized it was you on the call here today. Some of the calls we had with you were helping me get the beginning thinking around how to achieve this. And all of this is straight equity driven, sort of like, why do people look like myself, Vernon, and Georgia, and people from Bosnia that might look like you and not use our traditional mental health system? And can we use targeted universalism to adapt them in the largest scale need for psychological services that I ever think I've encountered in my lifetime?
I think one of the things, and Courtney, that was extraordinary sharing, and it is a significant and very grave concern. One of the other things that I know we have been uncovering, and as you could see from my string of letters after my name, I am with HHS in Region 1. That's the 6 New England states. And in doing the work with partners and hearing from other sectors, we know that the broadband and internet capabilities is a significant, what is now becoming identified as, fortunately, social determinant of health. We want people to connect to their providers for critical interventions, such as what Courtney mentioned, or for their substance use peer support group. However, that the accessibility of either internet or rigorous broadband that is stable is not universal. It's not in every community, and nor is it in every community in the same ways, or may even have an affordability aspect to it. So these are other things that we're learning through this that are essential to the health of a community. It's almost becoming, as I'm not the first to say this, it's what electricity was to us 100 years or so ago. Broadband is that essential to how we are operating and functioning as society. So the broadband issue became clear, even for not just telemedicine or telesocial services, but tele-education, school, making certain that our children are connected. It's a whole of society sort of concern that's been sort of elevated there.
If I could offer, I think, a lesson learn, and we continue to, I think, struggle with this, is the intersection of a health crisis and emergency management. You know, you have emergency managers, as you well know, right, responding to disasters, man-made or natural. And then you have a health structure that really isn't designed for, especially long-term disasters. And how do you ensure that you can combine the capabilities that both bring to bear in the response? I was the chief for the National Response Coordination Center at the beginning of the pandemic, when initially HHS was overall responsible. And then because of the coordination across the entire US, all 66 jurisdictions, there was a coordination requirement needed. And so FEMA was activated as a lead federal agency for coordination in support of HHS. And we had to learn. Certainly we had a pandemic playbook that we had on the shelf, but those are to kind of start you moving forward. But then it's a free play, right? You have to react to the actual environment you're in. And you know, as I came into Region 1, you know, I got a chance to see at the state level that the states are struggling with the same thing. That you have these emergency managers focus on disasters, and you have the health departments, and so as CDC is working with the state departments of health on vaccines, the emergency management departments don't actually understand what's going on. And so, you know, at the state level, building a unified coordination group, if you would, so that there's a strong connection between the two departments, I think is integral for the response, and something I think all the states need to take a close look at in the days ahead. You know, God forbid we get another pandemic, we certainly want to learn our lessons from this one, and take advantage of what each organization brings, you know, bring their strengths to bear. But to do that, you have to have open and consistent dialogue. And I will tell you, it's been a challenge from the get-go. Operation Warp Speed and CDC work directly with the states. HHS, ASPR, OASH, FEMA weren't really part of the conversation. And so when the vaccines started rolling out, we didn't know what the states were going to need for help because we had no idea what the plan looked like. So I think, you know, the after action report for this will really show the need for a stronger collaboration across the federal and I think the state departments to be able to look after all of our citizens. I did share in the chat reference to hesitancy. I did share it in the chat. So like a 4 or 5 minute video that attempts to get after specifically Black populations, but I think it's good for any population about the challenges with hesitancy. So I would offer that's a good thing to share. If you haven't seen it already, take a look at it and share it widely. I have certainly done so within FEMA. And then the last thing, and I'll see the mic, is when Courtney was talking about these, 20, 30-year-olds, not being concerned, part of it is convincing them to get the vaccine, even though their risk of fatality is very, very, very low at that age. The potential for them to carry it and give it to somebody who's not young is certainly there. And so I think there needs to be a different strategy for the vaccination based upon the type of group you're working with. So I think it's important that we develop it in all the communities, what resonates most. And there clearly are some cultures that are far more open to being vaccinated. I track the numbers daily for the Heinz Convention Center. And for Suffolk County, even though Asians are 1/3 of the population of Blacks and Hispanics in that county, they're far and above the largest group of color that is getting vaccinated. So it appears that they are far more open to it because they're all over that, whereas Hispanics and Blacks are not. And so I don't know if that's because the word's not getting out and being, people are being informed about it, but understanding why people aren't getting vaccinated, I think is a critical part, and it has to be done, Reverend Walker, at your level, at faith-based organizations and community-based organizations, having those conversations. So I think I've spoken long enough, but this has been a really, really challenging response, and it takes the entire community to respond to it. Thank you.
I would just add and underscore one thing about what Mr. Roy was saying, which is that I think that, we all knew that COVID was going to lay bare some of the structures and problems that we have within our society. A pandemic does that to any society. And I think over the last year, we've all had an opportunity to really be faced with what those realities are. And there are some very difficult issues that we have to tackle. These are issues related to confidence in government, good government, networks of individuals who support each other. It relates to structures that are fundamentally racist in our society. And this has been a complex interplay that has led to, a frankly public health catastrophe in the United States with more than 500,000 people dead. That has not been the case in other countries with much less resources than our own, who have successfully contained the pandemic with basic public health measures, not even including vaccination. So I think we are all going to have a reckoning as a society as this goes forward, so we can understand how we fix some of these problems, because these are the same problems that we are going to be facing from climate change. And we know that is how it works. And you've described it, Reverend Walker, with Hurricane Katrina. These kinds of emergency events, I think, are going to be happening with increasing frequency. They may not hit the whole country at the same time, but they will hit regions. And I'm sure Mr. Roy deals with these concerns all the time, but there's a lot of very important lessons that we need to learn from what's happened with COVID and apply them right away going forward.
This is a fruitful conversation. Question for you, Dr. LaRocque. Why is it that after a person receives the vaccination, it's observation for 15 minutes and not longer? Is it that if an allergic reaction is going to happen, it's going to happen within the first 15 minutes?
We went from the very big to the very specific, but I will say that the concern was for anaphylactic type reactions, and anaphylaxis is a very immediate hypersensitivity that the body has to something it's exposed to, and it usually happens very quickly. And the small number of events that were observed along those lines happened in a short period of time. So operationally, you don't have to watch somebody for a very long time before you know if they're having anaphylaxis. But I think you raise an interesting point that relates to just the logistics of all of this. Whenever each degree of complexity that is added to the vaccination campaign, it's exponentially harder. If I have to observe somebody for 15 minutes after they're vaccinated, well, that has a lot of operational implications for how you set up a vaccination clinic, which makes it hard. And every step of the way, whenever an element of complexity is added, it slows things down. For what needs to be really a mass campaign, these are not small decisions, not small impacts of these decisions. So I'll just make that simple point.
Dr. LaRocque, it just occurred to me when you brought that up when I was at the Heinz Center yesterday. You've got just a constant group flowing through there, and as I look, as both Reverend Walker, you and Courtney were talking about these mobile sites that you're working on. You know, it occurs to me that that 15-minute period is a missed opportunity for education on something that we want to share, right? And I recognize that I may sit down right now, you know, and 14 minutes from now I'll get up, and all the while more people are, you know, are just kind of flowing through. But still, you know, it would seem to me, whether it's a monitor with a 2 or 3 minute, you know, video like the one the one I put in there, but obviously if I already got the shot, you don't have to worry about the hesitancy, you know. But you know, it's a great opportunity for us to share a very short vignette or a very message because we have a captured audience. They're not going anywhere for 15 minutes. So I would think maybe an opportunity to take a look at that and just talk with people.
And some of our folks, we put in observation for 30 minutes that fit a certain criteria as well. So when particularly when we had a double dose vaccine, that time period was used to actually schedule people for their second vaccination. But when we set those up, we have medical reserve corps and people in queue management and so forth. So we are using that to have one-to-one engagement. Of course, we're helping people with Padlets, trying to schedule if they don't actually move to the next section afterwards. But that's where we're finding out like what neighborhoods they're part of, what concerns they have, and so forth. So it's a lot of human engagement. When I first was sent to Gillette to look at that operation, they had lots of big screens already built into the system, where I think playing a video that like what you're talking about is very possible. But back to the observation area, I remember my last conversation with Dr. Dorelnik from MGH. He had some stats around what the prevalence was of adverse reactions from any of the vaccines. And Dr. LaRocque, I don't know if you have seen that or been able to track that, but we had zero. So no one went into anaphylactic shock with us, and we had EMS on scene as the group manager for observation section. So something happened, there was someone right there that would address it, but we really had no emergency issues whatsoever. Over the first month of 4,000 people.
Yeah, we've looked at the data within people who were vaccinated in the MGB system, and I understand from what I've seen as well, it's been basically zero. So I guess one thing I would highlight from what you were saying, Mr. Roy, is related to just communications and how complex that has been during the pandemic. I mean, I think, communicating to people in a way that's accessible and understandable to them is challenging to begin with, but on top of it, we have now had a lot of evolving science and understanding that has made it complicated as well. But I think that, a message that really needs to get out around the vaccination is that we are not done with this pandemic. I think that people have seized on a very simple message that the vaccine is a ticket to normal. I think at least in the short term, everybody really needs to understand that we still need all of the other public health interventions that we have been doing all along to continue. We need continued, masking and distancing and hand washing and ventilation and workplace protections, because at this point we have still a lot of virus circulating here in Massachusetts and around the country. We only have, maybe a 25 to 30% of people vaccinated. And we have variants of the virus that have emerged and they're of high concern. So, I'm very concerned that we're not emphasizing, people are not hearing the message clearly enough that we are not through this yet. And it's been a rough year. I think people are eager to move on, but we are at a very fragile moment in our handling of this pandemic, and it is not the time to let up. So I think that's a communications issue, which needs to be thoroughly conveyed to the public.
Yep. Can I just add a little bit to the conversation about the 15 to 30 minute observation, and how that it is also an opportunity to do some really good education, continuing to educate folks. One of the methodologies that lends itself well to is social networking, knowing that each person knows someone else that they're probably going to go outside and talk to. So providing just clear information during that opportunity can have some additional benefit. Also providing individuals with maybe some ancillary resource that they may need. You know, COVID has done quite a job on you know, all of society. There are people who are still food insecure. So if we know of food banks that have, provide that, you know, maybe a one sheet of resources, you know, emergency resources that you may need in the interim. The other thing, though, that 15 to 30 minute wait period allows for is for people to actually sign up or enroll in the CDC's vaccine health tracker called V as in Victor -SAFE, SAFE. They're able to communicate. The individual is communicating directly with CDC on their experiences post vaccination. So does your arm hurt? There are 3 very simple, from what I understand, questions that are asked initially, and they'll keep in contact with people periodically for, I think, a 12-month period. But it's really to understand how people experienced their vaccination. And that information is so hugely important for us to know as public health and the scientists in thinking about, of course, communicating important information to communities as we go through this. So I just wanted to put that out there.
Yeah, I'll just say I did the V-Safe program after my vaccination, and I think it's really essential information. It provides a touch point as you are getting the vaccine, and it gives good public health data. Of course, you have to have a mobile phone, a smartphone, in order to be able to do it. And I think one of the things that, you know, is emerging in the conversation that Reverend Walker, I know you're doing with crew and is so important, is what are the networks of communication that exist within a community, you know, to know about how we respond to an emergency event. And I think that's really an area that going forward from this crisis, I hope we will emerge with strategies for how to get information out to people in the event of need, you know, communicating networks of people, you know, what are the people pathways for getting information out well? What are the diversity of ways that people need to receive information? Yeah, that I think is a lesson to be learned from this as well.
Well, I know for our side, so based on the social media and the pre-existing trusting relationship side, those 220 partners, I think are our attempt in doing that. I wish we could actually do a document process studying what we're going through now to see how well we do. But I know when we surveyed them and how many touch points they have, when we're looking at vulnerable populations, elders, they were touching about 9,000 elders, school-based young people, another 9,000, and people in recovery, returning citizens, and so forth. It was a nice spread. And each of those 220 might represent an average of 3 staff. So that's how many humans. And we're about to do 2 or 3 community assessments with them. Some are from a continuity of operations standpoint around the impact on their organizations. Have you lost critical functions or critical staff that have died or had to move because of COVID-19? But then I don't think we actually have a good knowledge of what the world is experiencing. We watch the news and we can watch EMS polls and so forth, and what we're getting in terms of emergency management data where with people in numbers. But with this group of folks, we're asking them to, I think there might be, it might be like 4,000 to 10,000 data points we're going to get around what the residents are saying. It's kind of like a Casper study in terms of the recovery phase analysis of a disaster. That's a typical study, which is like, what are you seeing yourself in your household, per household? And then also, what are you seeing out in the world? Like with droughts, you'll say, have you seen more still water and dried up lakes? And then dehydrated animals on the road and mosquitoes. On the same sense, our sense is, are you seeing more agitated, angry people in the world? Are people wearing masks? Do you feel like people are social distancing? Even what's the general sentiment that you're seeing amongst your population? Did you have food insecurity at any point? Did you have to move to Brockton while trying to keep your child in BPS, the Boston Public School System, because of distancing or taking care of an elder? So we hope to get that kind of data so that we as a region can then say, here's what we know of the world, the closest we can get to actually living in people's actual homes with them. Here's what we know about the world, and we can design better systems to address that.
Yeah, because I just want to say that you're absolutely right, Mr. Gray. I mean, like that is the essence of it, and that requires resources and commitment and you know, a robust governmental response and preparedness. And I think that I'm hopeful that what we're investing now in COVID can prepare us. You know, that's what we really should be doing, is using this moment to build out those same structures that you're describing so that we're better ready for the next emergency.
Mm-hmm. And that is so true. This has really been a robust conversation. Question, Dr. LaRocque, could you explain or share with us the variants and how this coronavirus has mutated? And these new variants are popping up. Like, did it mutate in osmosis, or, you know, is this common for infectious disease to mutate? Did the epidemic or the pandemic in 1918, that the Spanish, what's been called as the Spanish flu, did that mutate, et cetera?
Yeah, thanks. It's an important question. I mean, let me just first make a comment about the historical element. You know, we've had pandemics affect human populations in the past, and we know that organisms can change their biology, and pandemics are affected by that too. So that's a historical fact. You're talking about the 1918 influenza pandemic. So that's a little different than what we're dealing with now, which is a coronavirus pandemic. But I'll just underscore the fact that this is just the biology of this virus. It's the same biology of all infectious diseases, which is that, you know, that is an organism that has its own genetic material. And RNA viruses, like the coronavirus in particular, are very sloppy when they make copies of themselves. When they infect a human like us, they're making lots of copies of themselves. And in the course of making those copies, mistakes happen in the genetic code. And sometimes those mistakes are advantageous to the virus, and they can offer it the ability to infect more people, which is ultimately what the virus is trying to do. And so we have already seen that with this virus, that it develops by chance an advantageous change that allows it to infect more people. And when you have a virus that is able to infect more people, ultimately that's the one that takes over. And that has definitely been the case in the kind of dynamics of this disease. You know, the thing that's concerning at this point is that, you know, some of these changes in the virus also have made it less susceptible to some of the immunity that we develop. It's trying to hide itself from our immune response too. So, you know, the main message is that we need to get this virus under control so that it is not reproducing so much, it is not having opportunities to make copies of itself, because that is not the position we want to be in. We want to suppress this virus so that it does not have so many opportunities to have these advantageous mistakes happen. We know in the United States that the variant that took over in the UK is already becoming the predominant variant in the US, and it is more infectious to other people. And so we are battling against what the virus is doing with its biology and the response that we are mounting. And I think the coming couple of months, we are going to see that dynamic play out. I'm very concerned that we have not suppressed the virus enough in the United States. We are allowing it to continue to replicate at high levels in people. And so we're just setting ourselves up to be kind of in a weaker position than we would ideally want to be in. We have lots of opportunity and promise from these vaccines, and we need to pair that with all of the other public health interventions that we know work in order to suppress the virus. That will make our job easier in the long run. It's all about biology when it comes down to it. Like the virus is what the virus is, and it is going to do what it is going to do. And we want circumstances to be such that it doesn't have the upper hand.
Thank you. And I know we're approaching, we're a little past the 12:30 mark. Any other final questions from some of our esteemed guests here, or any final thoughts? I think we, at some point, maybe should reconvene this, and we can certainly talk offline about that. But any questions from our wonderful folks who have joined us? And
I'll have to apologize. I'm back to back, so I have to apologize and jump off. But I really appreciate seeing folks I knew, and would love to connect more with Anna, Dr. LaRocque, and of course, Vernon. William and Georgia, really good seeing you.
You too as well. Have to go as well, sorry.
Thank you for having me.
Thank you. Thank you, Anna. Thank you, Reverend Walker, and Will, thank you.